Alright, hi guys, very good evening to all of you, and welcome to our today's YouTube session, which has been specially planned for 2 days, that is today and tomorrow. Today we'll be discussing some special MCQs on Autonomic, nervous system and general pharma. This class will be relevant for all the students those who are planning for NEET PG, that is upcoming NEET PG, and also for the FMG students. Do remember, the question standard has been set according to the same. Apart from that, tomorrow I will be talking about your other topic, which is cardiovascular system and renal system. Along with that, I will also discuss antidyslipidemics. That will be tomorrow again the same time, which is 10 p.m. on YouTube. So I'll be starting the session very quickly. For all the students those who are live right now, please give me a quick confirmation if the audio and video both are fine. If I'm clearly audible and visible to all of you guys, please give a quick confirmation. Please reply, in this live chat option, all of you can reply here. Dr. Ashok, Shilpa, and all the other students, if everything is fine. Dr. Shraddha Shahu. Okay, great. So let's get started. A quick announcement that if you guys are subscribing to Unacademy now, you can use the code Pharma10 to avail a 10% off. Do remember, it's very easy to memorize the subject itself. Pharma 10 will be a code. So right now, for the next 3 to 4 days, that is from 27 to 30th, if you're subscribing in Unacademy Plus or also in the Iconic, either Plus or Iconic, in both of them you can avail this benefit. Iconic will be having Unacademy Plus prep letter both, plus all the benefits that is present on the Unacademy. Okay. If you have any doubt, you can call on the given number. This is the helpline number that you will be attended by one person from the platform. One of the new batch that has been introduced is Target NEET PG 2023, in which all the 19 subjects will be covered in a very comprehensive manner. The duration of this course will be around 9 months. So in 9 months, that is going to be quite a long time. That means it will be highly comprehensive. It will be very detailed course, definitely relevant for all the student planning for the upcoming NEET PG examination. This course will be equally beneficial for the INICET student as well, because once again, the syllabus is almost same for these examination. It's just the pattern of question which is little different. So in this, I'll be covering pharmacology in around 54 hours. 52 to 54 hours I'll be covering pharmacology here. Then another NEET PG 2023, this is specially designed test and discussion batch, live test and discussion batch. Apart from that, you can even watch it, the recorded session as well. This is a 6-month course starting from July 1. In this, the pharmacology, I'll be taking care of pharmacology in around 12 hours, 12 to 14 hours. 12 to 14 hours I'll be taking care of the pharmacology, or maybe a little more than that. Okay. Iconic prices definitely are going up, so if you guys are planning to subscribe, this is the right time. In these 4 days, you make a call and make sure that you are already a part of the platform and continue the learning. Right, it's time for us to start our session. As I told you, it's a special class, a specially designed question for our NEET PG and FMG, and also for the INICET on topic which is general pharma. I hope all of you guys are ready. Let's go to the first one. Medical devices are sold under this Act of Drug and Cosmetic Act 1940. So in our country, we are having Drug and Cosmetic Act compared to United States, where they have US FDA. Please go ahead and tell me which one do you think is the correct answer if this kind of question you are going to receive in the examination. Schedule H1, R1, Schedule W, or Schedule Y. What do you think is the correct answer? Please go ahead. All of you, please start replying. As soon as you see the question, even if it is going to be right or wrong, take a call. We are not going to judge you. Dr. Varsha, Deepak, Hemant, Aisha, Shraddha, Shilpa, all of you please. Schedule H1, Sovik is saying CW, okay, others are saying D, that is Y, okay. Alright, so all of you are marking the answers. You are choosing the option which is other than the correct answer. So first of all, let me give the correct answer, which is going to be Schedule R1. Schedule R1. this is mainly for Drug and Cosmetic Act, the medical devices under Drug and Cosmetic Act. Important medical devices, their manufacture, and what are the important changes that they needed to do, that will be all coming under Schedule R1. Do remember, it is different from Schedule R. Schedule R that we are having, it is mainly for storage of contraceptives. For the contraceptives, storage and manufacture. Contraceptives, storage and manufacture. Like for example, let's say condoms. So at how should they be stored, their expiry period, how long they can be used, everything will be coming under Schedule R. So do remember, reproduction को control करने वाले R, and R1 आ जाए तो it will be different. R1 is mainly for the medical devices. Many of you have even marked Schedule H1. Guys, H1 is one of the schedule mainly to check over the unauthorized sale of antibiotics. To check over unauthorized sale of antibiotics. In order to control over the increasing rate of resistance, we have Schedule H1. And all the drugs, those who are coming under Schedule H1, if you see the drug strip, at one side, on the left hand side over this, they will be having one red line here. All the drugs that are coming under this one, Schedule H1 will be having a red line. So Schedule H1 means this drug is strongly under check, and this should not be given without medical prescription. And mainly we are talking about the antibiotics here. Okay? Schedule W, many of you have replied. W जो worldwide वैसे ही मिलता है, worldwide वैसे ही मिलता है. So that will be, this is for the generic drugs, generic drug manufacture and sale. Schedule Y, many of you have even marked option D, like Dr. Hemant and other students. So Y will be mainly for clinical trials. So why should I prescribe this drug? Let's do the clinical trial. Whenever anyone asks, okay, why should I give this drug? Why should I take this drug? So you can say as a pharmacologist that yes, let's do the clinical trial, and we can know that whether the existing drug is better or this newer one is better. So just a way to remember, H, all the drugs that should be sold on a prescription of a RMP, right? RMP के prescription के बिना जिस drug को ना दिया जाए, that will be H. Do remember, in this H, every kind of drug will be coming. Antibiotic, anti-epileptic, anti-hypertensive, all the drugs that should be sold on the prescription of a RMP, that will be RMP prescription required for sale. All the drugs that should be sold on prescription of a RMP, that is H, but H1, it is mainly for antibiotics. I hope I have made this pretty clear. And a quick revision also, category X that we have, Schedule X that we have. Schedule X, this is for what? Schedule X, anyone? X, मैंने क्या बताया था आपको क्लास में, रेगुलर क्लास में? X याद करें अपने साइको को, साइको X को. Recall your psycho X. So all the psychotropic drug that require a specific license for manufacture and sale. Right, so Schedule X, all the psychotropic drug that require a specific license for manufacture and sale, they are having high abuse potential, and they cannot be sold even with the prescription. They can only be procured through a proper channel, like LSD or opioids, LSD, opioids, ketamine. These are the example of the drugs coming under Schedule X. This has been asked in the past. So as you saw that quickly, I have summarized the entire drug and cosmetic. I mean, not entire, but the important ones I have summarized. All of the following drug comes under Schedule X of the Drugs and Cosmetic Act except. So if you guys have been listening to me, you can easily mark. Please go ahead. Please go ahead and mark this. All of you? Yes, Shereen, very good. Shereen Peterson, that's correct. They have high abuse potential. So what do you think about this question? All of you, please. Comes under Schedule X. Do remember, category X is different from schedule. So category may we have a T here, and we talk about teratogenicity. Category X may we talk about teratogenicity compared to schedule, where we are talking about the sale, manufacture, distribution, everything. So all of the following comes under Schedule X except ketamine, barbiturates, phencyclidine, जिसको हम एंजल डस्ट के नाम से भी जानते हैं, एंजल डस्ट, and other one is promethazine. Correct answer that we have, and just quickly giving you the correct answer. Promethazine, this is one of the highly sedative H1 antagonist with centrally acting anticholinergic property. Centrally acting anticholinergic property. The promethazine, it is used in multiple condition, like for example as an extrapyramidal symptom like dystonia, akathisia, secondary Parkinsonism, and they are also used as a first line drug of choice in a patient with the motion sickness. So motion sickness में the drug of choice we still use hyoscyalamine. This is also the first line drug. ठीक है? This is also the first line drug. Promethazine. It's the H1 antagonist, highly sedative H1 antagonist with the anticholinergic property. Others are actually coming under the Schedule X. According to FDA drug list classification, which of the following agent is classified under category X? So I think this is the point that I was raising in the previous question. A drug which is categorized under category X. So category, as I have told you, for the teratogenicity. Okay, so diazepam, hydralazine, valproate, doxylamine. All of you please try, and you will end up revising many important concepts in these session of ANS and general pharmacology, and they are very high yield, or very commonly question can be framed from these topics. All of you please try. Yep. So I think Shireen, very good doctor. Varsha, excellent. Simi, Aisha, all of you are actually going ahead with the same option. Very nice. Hemant is studying A, diazepam. Okay, so first of all, Hemant, A is category D. D का मतलब होता है दे सकते हैं. Just a way to remember, I am telling you, D is दे सकते हैं if benefit is more than the risk. If benefit is more than the risk, then दे सकते हैं. Usually ये भी avoided हैं, and they have also shown to have some teratogenic effect. But if benefit is more than the risk, they can be given. Like for example, epilepsy during pregnancy. So if there is active epilepsy during the pregnancy, you can give diazepam. They are category D. There was a time when they were keeping valproate in category D also. They were telling all anti-epileptic drugs, but looking at the rate of valproate causing teratogenicity, they are associated with teratogenic effect like neural tube defect by the name of spina bifida. Now they are mainly bifida. They are mainly classified under category X drug. No matter what is the benefit, we do not give this X mark, a dangerous mark. No matter what is the benefit, you don't give this. Same as other example. You might be asking, sir, other example. Okay, so we have multiple, like for example warfarin in the first trimester, and like for example carbimazole or methimazole in the first trimester, or thalidomide associated with your phocomelia, carbimazole associated with your scalp defect, warfarin, fetal warfarin syndrome, also known as Contradi syndrome. This can cause scalp defect, carbimazole. Thalidomide causing phocomelia. So they are all category X. Doxylamine, as I told you, it is very safe kind of antihistaminic drug. They are categorized under category A. They are safest actually. In the animal model, in the human model, trials have been done. They have shown to be safest. There is no teratogenic report. Okay? So they are in fact drug of choice in a patient with the morning sickness. Morning sickness. Doxylamine. Hydralazine is also a potassium. Hydralazine, yes, a potassium channel opener, and they are a preferred drug in hypertension in pregnancy, and also in the hypertension emergency in pregnancy can be used. It's a safer drug also. Okay? They have not shown any teratogenic risk, and neither there is any report so far, and there is no human trial also. So अभी है नहीं, ठीक है, there is no human trial done also, but teratogenicity भी reported नहीं है on the hydralazine. So can be given in pregnancy. Okay, next one. True about the ganglion blocker, a question which is totally based on the concept. one of my all-time favorite question which I always ask from the student to check their concept. If I have to check their concept, I'll be asking this question. So you read the questions, each of the option very carefully, and expect this kind of question in your examination. Parasympathetic ganglion blockade can cause tachycardia. So we have two kinds of ganglia. We have, let's say, there is sympathetic ganglia, and we have, let's say, parasympathetic ganglia. And this is, let's say, sympathetic ganglia. So wherever there is a transmission center in between the nerve fiber, we call them as a ganglia. So parasympathetic ganglion blockade can cause tachycardia. Sympathetic ganglion blockade can increase the blood pressure. Atropine inhibits all the ganglion. Nicotine is a non-depolarizing ganglion blocker. I believe all of you can easily mark this. Most of you other students are also try participating in this purely based on concept. Okay, very good. So let us go one by one. Most of you are marking A, so I'll start my explanation from D. Nicotine is a non-depolarizing ganglion blocker. Do remember, guys, it's nicotine. It's acting on the ganglion. Okay, yes, it can act on the ganglion. It's an NN receptor agonist. It will never be a blocker. It can be a ganglion or a stimulant actually, like nicotine poisoning. Okay, it will always stimulate the ganglia, NN receptor. Atropine inhibits all ganglion. Do remember, atropine has no activity on the ganglion. Atropine actually is a non-selective muscarinic antagonist, M1, M2, M3 blocker. Sympathetic ganglion blockade can increase the blood pressure. If this is sympathetic and we have parasympathetic, imagine if I am going to block the sympathetic ganglia. If I am going to block this sympathetic ganglia, the sympathetic tone will markedly reduced. If I block sympathetic ganglia, the sympathetic tone will reduce. What will happen to the parasympathetic? The parasympathetic will be more as compared to the sympathetic. Therefore, a sympathetic ganglion blockade will increase the blood pressure. This statement is incorrect. Parasympathetic outflow बढ़ेगा, so there will be bradycardia, no, not tachycardia. So increasing the blood pressure कोई सवाल ही नहीं. There is no question of increasing the blood pressure. Now other one that they are telling that parasympathetic ganglion blockade can cause tachycardia. So just see, if you are going to cause parasympathetic blockade, let's say if you are going to block this one, then you can easily understand that sympathetic tone will be high. If you block this, sympathetic tone will be high and they can actually increase your heart rate. So as simple as that, the correct answer for this one is most of you have given that parasympathetic ganglion blockage can cause tachycardia. Definitely yes, a definite true. Okay, all other options as I have ruled out already. I hope all of you guys have got this. Parasympathetic blockade can lead to sympathetic firing, increase sympathetic tone, that will be increasing the. So this is just a theoretical question actually. We do not have any selective parasympathetic ganglion blocker or sympathetic ganglion blocker. Do remember this. This is just a theoretical question. Okay. Next question. Which of the following receptor action aid in the management of the hypertension? So this is also I ask again and again, just to check your basic concept. Alpha 1 agonist, beta 1 agonist, alpha 2 agonist, beta 2 agonist. Think before marking. Think before choosing your option. Which of the following receptor action aid in the management of the hypertension? Total conceptual question, guys. Total conceptual question. Other students also please take part. Dr. Ahona Ghosh, Hemant, Simi, Deepam, Shireen Peterson. All of you are marking D. Okay, there are some in favor of C as well. Okay. Let me talk very quickly. Guys, alpha 1 agonist, we all know that alpha 1 agonist will cause actually the vasoconstriction. Any vasoconstriction will increase the blood pressure. I think it's pretty simple. Any vasoconstriction will increase the blood pressure. Beta 1 agonist, again like dobutamine, epinephrine, they will increase the heart rate. And again the BP will increase. Beta 2 agonist, I'll give you an example like salbutamol. So salbutamol at the higher dose, they actually increases the risk of tachycardia, salbutamol, terbutaline, है ना? Have you ever seen salbutamol being used in the management of the hypertension? Anyone who has seen salbutamol being used in the management of the hypertension? Please tell me. But we have seen alpha 2 agonist. We know a very good drug known as your alpha methyl dopa, and we also know one more drug known as your clonidine. So alpha methyl dopa and clonidine are the two drugs that are definitely utilized in the management of the hypertension, right? They are also safer in the pregnancy. In fact, alpha methyl dopa is a preferred drug for chronic hypertension in pregnancy. So alpha 2 agonist definitely I can utilize in the management of the hypertension, but not the beta 2 agonist or any of the others. Okay? Although we are using alpha 2 agonist, but as we all know that alpha 2 receptors are mainly present over the pre-synaptic receptor. So whenever there is alpha 2 receptor ka agonistic activity, they will self-inhibit themselves. We call them as an autoreceptor. They are going to inhibit the release of the noradrenaline. They are autoreceptors actually. Therefore, although I am giving alpha 2 agonist, but this alpha 2 agonist, they will be producing centrally mediated sympatholytic. They are known as your centrally acting or centrally mediated sympatholytic property. SL is sympatholytic actually. Sympatholytics. We are giving alpha 2 agonists, but they are sympatholytic drug. Do remember that. Okay? Yes, they are the autoreceptor, autoregulators. Okay? So alpha 2 agonists definitely we can use. All of the following drug can cause which of the following drug can cause bronchoconstriction? So which drug can cause bronchoconstriction? Go ahead please. Surprise me with this. Adrenaline, parasympatholytic drug, phosphodiesterase 3 inhibitor, timolol. Purely based on concept. If anyone has ever done any kind of mugging up or ratification that we say, usually you won't be able to do this. Totally concept based. Simi Kesri is telling D. Other students also please take part. Prakhar, Prabhakar, D. Okay. So this is usually going to be the level of your usual examination, but don't expect a single line of question like this. A patient, a 55-year-old asthmatic patient or 30-year-old asthmatic patient presented with the following condition. There is a precipitation of the bronchial asthma. Which of the following agent can further precipitate? ऐसे करके question आ सकता है. Which of the following agent can further precipitate? Expect question like this. Now I wanted to cover more number of question on this platform, so I am actually giving this kind of question. Sometimes we have clinical as well. But do remember that even the simplest of the question from ANS topic or from general pharma, you will be expecting them in form of clinical based scenario. Okay? So correct answer, as most of you are giving it here, is timolol. That's actually correct one. Timolol is actually the correct answer here. Alright. Now timolol, you might be wondering how. So do remember, it's a non-selective. It's a beta blocker. It's also a beta 2 blocker. So undoubtedly by blocking the beta 1, there will be decrease in the heart rate, but beta 2 is present on several areas including our bronchial smooth muscles. So when you block this, normally beta 2 has two properties, like they can cause vasodilation, they can cause bronchodilation, they can even cause tremor, they can act on the liver by and they can increase the plasma glucose level by increasing gluconeogenesis and glycogenolysis. So different action of beta 2 are there. So when you block the beta 2 over the lungs, they will be leading to bronchoconstriction. So definitely timolol is a drug that can always precipitate, and this question has been asked in AIMS a couple of times, also in FMG a couple of times. So which of the following anti-glaucoma drug can precipitate or should not be given in bronchial asthma patient? That your answer will be timolol. A phosphodiesterase inhibitor, a very good drug, most of you must be aware already, by the name of theophylline. Theophylline, it's a phosphodiesterase 3 inhibitor that will be causing bronchodilation. Parasympatholytic is M3 antagonist. We all know drugs like your ipratropium, tiotropium, no? Ipratropium, tiotropium. They are bronchodilating in nature. Adrenaline definitely is a bronchodilator because it's a sympathomimetic drug. By acting on the beta 2, they can cause bronchodilation. In fact, in several conditions, adrenaline by inhalational route is given for the bronchodilation purpose only. Okay? So correct answer that we are having for this question is going to be D. D is the correct answer. Next one. A known asthmatic and hypertensive patient who was on atenolol for hypertension visited your clinic. He is already taking a drug by the name of atenolol. He is having an asthmatic patient episode. He was prescribed salbutamol for the immediate relief for his bronchial asthma, but did not respond to that. Which of the following is the next best bronchodilator? So look at the question and choose your next best bronchodilator. I think it's pretty simple. On the basis of the previous question only, you can easily solve this. You have atropine, steroids, ipratropium, physostigmine. Okay. Very good. Most of you have actually given ipratropium, tiotropium that we have, or I can say any of this muscarinic antagonist. These are the preferred bronchodilator. These are considered as the preferred bronchodilator in all the patients, those who are on beta blocker. So if there is a patient taking beta blocker, in that condition, the preferred bronchodilator is going to be any of the muscarinic antagonists like ipratropium, tiotropium. Okay? Others like steroids. Do remember, steroid does not have any active bronchodilating property. They increase the sensitivity of beta 2, yes, but they do not have direct bronchodilating property. There is no bronchodilating action. Direct bronchodilating action is not there with the steroids. They can reduce the inflammation. That's a different thing. Correct answer for this one is C, ipratropium. False about beta blocker. So you have to read each of this question very, very carefully to come up with the answer, because you are going to choose a false. Landiolol is an ultra short acting cardioselective beta blocker. Diacetolol is the active metabolite of acebutolol. Is it? Celiprolol is preferred beta blocker in asthmatic patient. Sotalol has potassium channel opening property. So for all those who have read ANS or attended ANS, just by looking at this option, you can easily pick that yes, the correct answer will be this. Very good, Prakhar, Achan, both of you are going ahead with the C. Okay, you have to choose a false, by the way. I have already underlined. Make sure that you are not making mistake. Shireen is choosing A. Other students, and a rule of thumb I am telling you, most of the time it happens that when you get to see any atypical options, some new option, you think about that, and you most of the time you go ahead with that thinking that no, this will be the answer, है ना. तो कई बार इस ट्रैप में नहीं पड़ना है आपको, है ना. एटिपिकल ऑप्शन के वाले ट्रैप में नहीं पड़ना है. दिस इज ऑलवेज ट्रू फॉर मोस्ट ऑफ अस, मोस्ट ऑफ द स्टूडेंट्स, that when we get to see the atypical or some new option, we think okay, this could be the answer possibly. I think Prabhakar is the one student who has actually got this very correctly and giving a definite reason as well. Very good, doctor. So Sotalol here, as I told you, it's not a potassium channel opener, guys. It's a potassium channel blocker. No, it's one of the beta blocker with a potassium channel blocking property. That is why this class of drug, it is classified under class 2. It is classified under class 2 and class 3 antiarrhythmic drug. Class 2 and class 3 antiarrhythmic drug. So it does not have potassium channel opening. However, if you are asking, sir, okay, do we have any potassium channel opener, a beta blocker with the potassium channel opening property? With potassium channel opening property, do we have any? Yes. Telisolol. Telisolol is the one that is having beta blocker with the potassium channel opening property. Okay. TDClol. Now many of you are marking C. Celiprolol is a preferred beta blocker in asthmatic patient. That's actually a true statement. Now why is that so? Because celiprolol as a drug also has a beta 2 agonistic property. Celiprolol as a drug also has beta 2 agonistic property. Because of this beta 2 agonistic action, and they also have a nitric oxide releasing property. Now because of that beta 2 agonistic property, this beta blocker, it's a beta blocker. Okay, it's a beta blocker, cardioselective beta blocker, but it is also having beta 2 agonistic property. Because of that, it is most preferred in asthmatic patient. It will not cause bronchoconstriction. In fact, it will be promoting the dilatation. Diacetolol, yes, it is active metabolite of acetylol. Landiolol is ultra short acting cardioselective beta blocker. That is actually true. Now when we talk about short T half life or shortest acting beta blocker, this will be, earlier we were actually telling it is esmolol, but ever since we got this landiolol, esmolol is the next choice. Now why is that so? Landiolol is lasting for 4 to 5 minutes compared to esmolol, who is lasting for 8 to 10 minutes. Now do the math yourself and tell me which one would be the possibly the shortest acting. Now it is landiolol actually. Both of them are shortest acting because they are rapidly metabolized by RBC esterases. The reason is same for both. Dr. Ramesh is asking, longest is Nadolol? Yes, doctor. Nadolol is the longest acting. It's a non-selective beta blocker. Longest T half-life among the beta blocker. It's a non-selective beta blocker. Okay. All right. So let's go to the next one. Read the question very, very carefully and choose your answers. 55-year-old male from village with loss of consciousness, heart rate 140, increased body temperature, pupils are dilated. There is a history of intake of some plant product. What will be the correct sequence of management for this? So sequence वाला question NEET PG का हमेशा favorite होता है. What is the next order? What is the next best step? Next best investigation? Next best drug? है ना? In the management of this patient. So first of all, you will have to make a diagnosis and then only you will be choosing the answer. Start patient on atropine followed by enzymes. Start patient on epinephrine followed by benzodiazepine. Start patient on benzodiazepine followed by intubation. Start patient on physostigmine followed by hydration. Very good, Aisha, Sherleen, Hemant, Prabhakar. Okay, so possibly most of you have got this diagnosis. Possibly this is a case of belladonna poisoning, or let's say atropine poisoning. And atropine poisoning, or you can even call it as a belladonna poisoning because patient from village. So plant product belladonna poisoning का intake often common होता है. And what are the things that you saw? See, increase in the heart rate, everything will be on top. Pupil also on the top, dilated. What will be the body temperature? Increase in the body temperature. So everything will be on the top. In atropine poisoning, everything will be on the top. And the antidote of choice for atropine is going to be physostigmine. Correct answer is going to be D. D happens to be the correct answer. Okay. You will not be choosing A. I hope all of you guys have got the trick here, because in atropine poisoning, why and how can you give atropine? In a patient with atropine poisoning, you can never give atropine, no? Atropine poisoning में खुद atropine कैसे दोगे? That's wrong, right? Start patient of epinephrine, it has no relation. I mean, epinephrine or atropine, no correlation. ठीक है? Start patient of benzodiazepine followed by intubation, again no. ठीक? Antidote of choice will be physostigmine. Tertiary amine, which is a lipid soluble reversible acetylcholinesterase inhibitor. थोड़ा सा picked up question है, especially INI CT pattern kind of question. Arrange the following anticholinergic drug in order of their inhibition action over acetylcholine synthesis and release. So you have to arrange in order of inhibition. So from top to bottom, ऊपर से नीचे अगर acetylcholine की synthesis होती है, so what all drugs, or how can you arrange this? So botulinum toxin, Vesamicol hemicolinium. All of you please try. Even if it is going to be wrong, if you think that it's, you're not sure about it, try marking. At least you will know that your guesses are going right or wrong. So you can utilize the same trick in the examination as well. Most of you are going ahead with the 3 to 1. Very good. C. So C will be 3 to 1. That is very good. Initially, the uptake of choline will be inhibited by hemicolinium. Then the entry of this acetylcholine into the vesicle is inhibited by Vesamicol, and the release of this acetylcholine in the synaptic cleft will be inhibited by botulinum toxin. So I always used to say that, remember HVB in the same order, HVB in the same order, hemicolinium, Vesamicol and botulinum toxin. HVB का मतलब यहाँ पे होगी. So 3 to 1 will be the order from top to bottom. Which of the following is true arrangement of the treatment modality for a patient presented to you with anaphylactic shock? Be very careful while choosing your option. It may look very easy, but you might choose the wrong option. Go ahead please, all of you, try marking. Which of the following is true arrangement of the treatment modality for a patient presented to you with anaphylactic shock? All of you please try. Hemant is in favor of C, Prabhakar is in favor of D. Okay, so let's read option A. Adrenaline 1:1000 IM, repeat, then IV. Adrenaline 1:1000 IV, repeat, then IM. Adrenaline 1:1000 IV, repeat, IM. Adrenaline 1:1000 IM, repeat, then IV 1:10,000. So I think all of you guys can get this, that the preferred one that we have is always adrenaline 1:1000. 1:1000 ka we will be taking 0.5 ml and we will be giving intramuscular route. Not responding, then we repeat, and if still not responding, now you can give IV or also intraosseous. Do remember, in the bone, if IV route cannot be made, if there is no excess of IV, you can give intraosseous as well in the same concentration 1:1000. Okay, so here the correct answer is going to be D and not any other option. C, immediately. Why will you or how will you start IV in an anaphylactic shock? Immediately or IV? और IV अगर दोगे भी, so 1:1000 पे तो कभी नहीं देंगे. It's more toxic, है ना? So IV route, IV it's always diluted to 1:10,000. ठीक है? Propranolol is a preferred drug for. This is one of the PYQ. Propranolol is a preferred drug for which of the following? Go ahead please. Tremor, pyogenic granuloma, infantile hemangioma, angle closure glaucoma, migraine prophylaxis. Go ahead please. Propranolol is preferred in what all scenario? It's a preferred drug for tremors like essential tremor, pyogenic granuloma, infantile hemangioma, angle closure glaucoma, migraine prophylaxis. Very good, Prabhakar. It's B actually, 135. For essential tremor, yes, is the drug of choice. For infantile hemangioma, the most common vascular tumor of infancy, is the drug of choice. For migraine prophylaxis, also is the drug of choice. Guys, we do not use in pyogenic pus, infective condition, no. We do not prefer them in a pyogenic granuloma. Infantile hemangioma, yes. Angle closure glaucoma में we do not have any role of propranolol. In angle closure glaucoma, either you reduce the intraocular pressure by giving pilocarpine or by giving mannitol. The best thing is always to do laser iridotomy, but we have no role of propranolol. We have beta blockers that are used in open angle glaucoma. Those are very few, like for example betaxolol, timolol and all. But again, propranolol is not available by the eye drop form. So the correct answer is 1, 3 and 5. Next one, false statement about clonidine. So read the question very carefully and choose. Preferred in diabetic diarrhea. Can be used in smoking cessation. Can cause sodium and water retention. Commonly causes rebound hypertension. So I think this question is very easy actually. And even just by reading options once, you will get the correct answer. I'm pretty sure. Anyone who is going to read it for the very first time, you will get it. Preferred in diabetic diarrhea, can be used in smoking cessation. Is it? Very good, Aisha. So you pick that. Not hypertension, no. Rebound hypertension is a very common side effect of the clonidine. It will be causing rebound hypertension. Rebound hypertension. Okay, not hypertension. In smoking cessation, yes, it can be used as a second line drug. Preferred in diabetic diarrhea. In fact, in diabetic diarrhea, it is the drug of choice. It causes sodium and water reabsorption. It causes sodium and water का reabsorption. So of course intraluminal fluid volume is lesser. It also inhibits your bicarbonate secretion. So if the bicarbonate secretion is lesser, there will be less bicarbonate loss. Of course, diabetic diarrhea में these are the problems that you will have to take care. Alpha 2 agonist that we have, it is also going to inhibit or decrease the level of acetylcholine. Cholinergic tone को ये कम करेगा, and therefore the motility will also be reduced. So alpha 2 agonist, they have some role, although they are going to decrease the noradrenaline, but there has some role also. They have shown to have some role on the cholinergic tone as well. They decrease the acetylcholine synthesis, therefore acetylcholine are released, therefore cholinergic tone over the intestine will also be reduced. Okay. So sodium and water reabsorption को ये promote करेगा, inhibit the bicarbonate secretion and also decrease the cholinergic tone at the intestine. So therefore, it can be utilized in a patient with a diabetic diarrhea. ठीक है? A drug of choice in diabetic diarrhea, in fact. True about GI of the G protein coupled receptor. My all-time favorite question. G protein पे I always ask question because I know every time there will be one or every alternate year there is one question. So last year there was, this year there was none, but in upcoming year you can expect. True about GI of G protein coupled receptor except. Go ahead please. An active component of G protein like beta and gamma activate the potassium channel. You have to choose and accept one. Activate adenyl cyclase causing breakdown of CAMP. Opioid receptor act by this. M2 and M4 act by this. So most of the option you can easily rule out if you just know what are the example of receptors acting by GI. Alpha 2, dopamine 2, opioid, alpha 2, dopamine 2, opioid. Then you have M2, M4, 5-ST1, 5-ST1, H3, H4, H3H4. These are the example of receptors. These are the example of receptors that are acting via GI. GI, and I used to say just remember ADOMs. एक तो मैं बोलता हूँ GS वाला बादशाह BDSH, like all the beta 1, beta 2, beta 3, dopamine 1, then 5 dopamine 1, बादशाह BDSS will be your 5HT4 and H4H2 wala. But here ADOMs, alpha 2, dopamine 2, opioid, M2, most of them you see there 2 is a favorite word here. 5HT1 there is one exception, and also H3 and H4, ADOMs. ठीक है, ADOMSH. If ever you have attended any of my general pharma, you know this mnemonic. GI वाले तीनों बादशाह ADOMs है ना. I used to tell you a story. So opioid act by this, of course. M2 M4 act by GI, yes. They never activate adenyl cyclase, guys. They do not activate adenyl cyclase. Activating the adenyl cyclase, it is mainly seen by GS. It is the GS that activate adenyl cyclase, and this adenyl cyclase will be causing breakdown of ATP into CAMP. Breakdown of ATP into CAMP. I'm sure all of you are aware about this, that GS causes activity via adenyl cyclase, not via, stimulate or activate adenyl cyclase, not the GI. In fact, GI inhibits adenyl cyclase, okay? Inactive component of beta and gamma, they open acetylcholine sensitive potassium channel, and because of that there is a efflux of the potassium. So that's a true statement. Yes, that is actually a true statement, that yes, the inactive component can actually open the acetylcholine sensitive potassium channel. Okay. G protein coupled receptor that does not act through opening of the potassium channel. This is one of the AIMS PYQ. It is one of the AIMS PYQ. This G protein coupled receptor which does not act by opening of the potassium channel. Go ahead. Each of these questions are very specially framed for all of you guys. Tomorrow again, today we are going to discuss a couple of questions more, but tomorrow again I will be live on the YouTube at 10 p.m. and on the Unacademy platform also I will be live at 7 p.m. and also at 8 p.m. So there will be 3 free sessions for all of you guys: 7 p.m., 8 p.m. and 10 p.m. 10 p.m. wala will be at the YouTube, and 7 and 8 p.m. will be on the Unacademy platform. It's a special class free for all of you guys. Go ahead please. Which of the following does not act by opening of the potassium channel? So in which type of G protein there is opening of the potassium channel? I just told you, no, opening of the potassium channel will be seen in GI, and mnemonic I have just told you is ADOMs. Okay? Mnemonic that I have told you is ADOMs. So dopamine 2, yes. 5HT1, yes. M2, yes. But angiotensin 1, they to act via GQ, no. They act via GQ. तो GQ के थ्रू काम करने वाले कौन कौन से रिसेप्टर हैं, क्विकली रिवाइज कर लीजिए. What are the receptor acting via GQ? Anyone can tell me? M1, M3, alpha 1, 81, ये तो होते हैं. Alpha 1, 81, 5HT2, TSH, 5HT2, TSH are some of the example of M1. This is M3 actually, not M2. M2 and 4 मैं बता चुका हूँ. This is M3 actually. एक टाइपोग्राफिकल एरर है, थोड़ा सा करेक्ट कर लीजिएगा. M1 and 3 because 2 is तो already active as GI that have already M3, M1, M3 and also M5. Also M5. ठीक है. Alpha 1, 81. So 81 will be active as GQ. GI वाले I have already told you in the previous question. These are the GI वाले. ठीक है. ADOMs. Which of the following pre-synaptic ion channel inhibition can cause release? Again, PYQ AIMS. PYQ of the AIMS. Which of the following presynaptic ion channel inhibition can cause release of the acetylcholine from the nerve terminal? Go ahead, please. Potassium channel, sodium channel, calcium channel, leaky chloride channel. So let us say you are having this presynaptic neuron and they have stored acetylcholine. So if you block which of the following presynaptic ion channels, so let us say you are having a potassium channel and let's say you also have a sodium channel. Let's just go ahead with this too. If you block sodium channel, you can understand that sodium channel, whenever they are open, they are always and always causing influx of sodium from outside to inside. And whenever potassium channel is open, they always cause efflux of the potassium from inside to outside. If you want to cause the depolarization of the neuron, which of the following step will you take? As simple as that. When sodium channel is open, they are causing influx of sodium. When potassium channel is open, they are causing efflux of the potassium. And if you want to cause the depolarization of the neuron, which one should you block? Because if you block sodium channel, the depolarization will not take place. But if you block potassium channel, what will happen? The potassium continues to stay inside and that will be helping in the depolarization. So blocking of presynaptic potassium channel will actually help in the depolarization and release, not the sodium calcium. Okay, so very simple concept. एम्स में पूछा हुआ है. Drug X is given in a control group and also in presence of two different drugs, phenoxybenzamine and propranolol. Identify drug X. So that means we are actually testing effect of a drug in presence of two different drugs and we are checking the drug interaction whether there is some interaction or not. Okay? So in a normal person, when you give a particular drug at this point of time, there is some change. Overall, there is a midline shift. That means the tone has increased. Midline shift, that means the tone has actually increased. But you gave phenoxybenzamine here. And at this point of time, when you injected the same drug X, now there is no effect. You gave propranolol here. In presence of propranolol, this is the effect, let us say, on the heart rate. This one will be the rate and this one will be the blood pressure. Okay. In presence of propranolol, again you see the effect. So image number 1, image number 2 and image number 3. If you look at image number 1 and image number 3, they are almost same. 1 and 3 are almost same. That means with propranolol, your drug X has no interaction. When you give propranolol and in presence of propranolol, when you are giving this drug, it is not causing any interaction. You give phenoxybenzamine, which happens to be one of the non-selective alpha blocker. This propranolol is a non-selective beta blocker. When you give alpha blocker and now when you give drug X, there is some change in the action. So which drug do you think? I hope this type of question you guys are practicing. They are not asking it, but we have seen some according to recent guidelines, they are being taught in the colleges, so you can expect this type of question at any time. In a control scenario, it is increasing the blood pressure. After phenoxybenzamine, this drug X is not showing any effect. After propranolol, again it is showing the same action. That means it is not having any interaction with the propranolol, but with the phenoxybenzamine there is some interaction. So what I am trying to say here is that which drug is having action on the alpha receptor. बिकॉज आपने अल्फा यहाँ ब्लॉक कर दिया अगर, एंड आफ्टर ब्लॉकिंग द अल्फा इफ यू गिव दिस ड्रग इज नॉट गोइंग टू वर्क. आपने अल्फा पहले ही ब्लॉक कर दिया, अब दोगे तो उस ड्रग का कोई इफेक्ट नहीं आएगा. ठीक है. सो विच ड्रग is acting on alpha receptor mainly and not on the beta receptor? Very good. Phenylephrine. So phenylephrine is going to cause vasoconstriction. The tone will increase. Vasoconstriction BP will increase. ठीक है. So let's say if you are going to give phenylephrine here, alpha receptors are blocked. Sorry, phenoxybenzamine here, alpha receptors are blocked. And if you inject the phenylephrine here at this point of time, at the point of X, do you think this drug X will be working? No. Phenoxybenzamine पहले दे दिया, अब phenylephrine दोगे तो काम नहीं करेगा. It will not work. Reason being the alpha receptors are blocked. Okay. But in presence of propranolol, they will do the same thing. In presence of propranolol, this is the heart rate. Now, if you give drug X that is acting as a alpha 1 agonist, phenylephrine is alpha 1 agonist, they will do the same action. They have nothing to do with the beta receptor. So there is no interaction with the propranolol in this condition. Making sense to all of you? How many of you did understand this? You have to practice this actually. You have to practice this a couple of times. This is a pure concept based question on the drug interaction actually. Pure concept based question. Go ahead, please let me know if you guys understood or if there is anything that you want to understand here. Do this question. Much easier one. True statement about the shown image. Drug B and C are equipotent. A is more potent than B and less effective than C. B is more potent and more effective than A. You have to find out a true statement, guys. Drug C is most potent. So potency order is something like this. As you move from this order, the potency order will go something like this. A followed by B followed by C. And if you look at the efficacy order, that is going B is equi-efficacious to C and A is the least efficacious, right? A is the least efficacious. So B and C are equipotent. This is wrong. They are equi-efficacious, but B is more potent than A. B is more potent than C. A is more potent than B. Of course, A is more potent because this is how the order is going. A is more potent than B and less effective than C. Of course, it is the least effective. B is more potent and more effective than A. See, B is more effective than A but less potent because this is the potency order. A, B and C, the potency order is going like this. Drug C is most potent? No, it is least potent. Drug C is least potent. And less effective than A? No, it is more effective than A. Okay, so this was a pretty simple kind of question. ये अभी रहने दीजिए. This one, do this one. Drugs given by topical route of drug administration. Please go ahead. Which of the following drug can be given by the topical route of drug administration? Ketoconazole, rotigotine, rivastigmine, cyclopyrox, warfarin. I hope all of you guys are already aware of the definition of the topical. Site of action is same as site of administration. So where you are going to administer the drug, the site of action will be at the same position. Ketoconazole, rotigotine, rivastigmine, cyclopyrox, warfarin. Which one do you think? Ketoconazole. All of you are marking C, 1 and 4 only. Prabhakar is marking A, first mark B, then marking A. Other students also please take part. So the site of action, see, ketoconazole, it is given topically. Let's say in the seborrheic dermatitis or in a patient with dermatophytosis, where will be the problem? You will be applying that directly. So of course it's a topical. Rotigotine actually is a transdermal patch. What is rotigotine, guys? It's actually a transdermal patch. Rivastigmine is also a transdermal patch. Cyclopyrox is an antifungal drug. This will also be applied. It is used in dermatophytosis in form of lotion, cream. So this is also topical. Wherever the problem is there, you are going to apply at the same place. Warfarin to systemic है ना? Warfarin to systemic है. It's given by the oral route. So 1 and 4 only. Transdermal is not a topical route of drug administration. Remember, है ना? Transdermal also comes under systemic because via capillary absorption the action will be seen. We'll see one last question here. This is okay. This one. In humans, the drug metabolism result in a product that is. Last question for the day. In humans, the drug metabolism result in a product that is less water soluble than the original, more lipid soluble than the original, more likely to be reabsorbed by the kidney tubules, less lipid soluble than the original. Go ahead, please. The drug metabolism. So main aim of the metabolism. What is the main aim of the metabolism that we say? Main aim of the metabolism is to convert any active drug or lipid soluble drug to water soluble, or we can even say a non-ionized drug to ionized, non-polar to polar compound. So our main aim is to make these drugs as water soluble so that they can easily be excreted. So option A is telling less water soluble. Are you trying to make less water soluble or more water soluble? What are you trying to make? Are you trying to make less water soluble or more water soluble? You're trying to make more water soluble, no? More lipid soluble. See, if you make it more lipid soluble, it will be reabsorbed back in the body, because we wanted to make less lipid soluble, right? Or more water soluble. More likely to be reabsorbed. It is the lipid soluble kind of drug that will be reabsorbed by the tubules. Less lipid soluble than the original. So of course, more water soluble and less lipid soluble. What do we want to make? More water soluble and less lipid soluble. So I hope all of you guys have got the trick here. It's a simple game of English. This kind of question you will also see in your examination. And I hope you guys have enjoyed the session of the MCQ General Pharma and ANS. We will have more such question tomorrow on cardiology and also renal system and anti-dyslipidemia tomorrow at 10. Again on the YouTube. Then once again I remind that at 7 p.m. and 8 p.m. we'll have two more sessions tomorrow on the Unacademy platform. These are also free session. It will be high yield MCQ and PYQ series that I have started, that will be done tomorrow. Okay? So I hope to see you guys in tomorrow's session. Thank you very much for your presence and attendance and for your active participation throughout. I'll be seeing you in upcoming classes. Keep revising, do your notes, and trust your notes that you're holding in your hand. Your notes are really very powerful tool for the preparation of examination like this. Okay? You just have to read it once, revise it as much as you can, at least 2 to 3 times. Make sure to do the MCQs on the topic, and that's it. Okay? Repeat the same. Alright? Is there any class and video for pharmacology university practicals? There are none so far, but if you guys want, we can have a series of pharmacology practical class in the special class section on the Unacademy app. So you just need to put a couple of if many of the students are interested, if we have enough audience, definitely we can schedule the practical classes as well. But as of now, we do not have none in my knowledge. I mean, I have not taken, because we don't get to see much of the students here, because it's mainly a NEET PG preparing platform. But if you want, we can have a discussion about all the pharmacology practicals, a quick revision and a discussion about those topics. You just need to put the request in the group that we have, and definitely we'll do consider that. Okay, so thank you very much to all of you. Ezekiel is telling, see, doctor, I have already given the answer as D. More likely to be reabsorbed, it will be mainly the lipid soluble, not the water soluble. Okay, chalo, bye bye to all of you. Have a good night, and